Mehta. He's going to talk about life-threatening bleeding disorders. I'd like to share the information that Dr. Atul Mehta is a product of NHL Institute of Medical College, and we studied together in the same class. To his credit, there are more than 7 books which he has written or edited on bronchoscopy. And some of his colleagues used to say that there are only 2 methods of doing bronchoscopy. One is wrong method, and the other one is Dr. Mehta's method. Dr. Mehta.
Thank you, Atul. Atul and I are more than brothers. People don't know about it. Not only that we share our names, we share a blood group. We have the same blood group, and you won't believe we are the same birth date. It's amazing that with that, because all of you, even though you're not a bronchoscopist or you are a so-called bronchoscopist, you all deal with hemoptysis. Now, again, Rajesh Bhai gave me 20 minutes. I prepared this talk, 80 slides and stuff, and then I come here and says, Dr. Mehta, you will not even have 21 minutes. He takes 25 and I have to stick with 20, but that's okay, he's the boss. So what I did was I cut down some of the topics I wanted to talk about, but I'm going to leave with you just 2 things. The etiology of hemoptysis. Okay, just the etiology of hemoptysis, and based on that, how do you manage bronchoscopy, hemoptysis? I have to thank, before I start, I thank Dr. Uday Prakash who let me borrow some of his slides. So part of my talk contains Dr. Uday Prakash, who is my mentor as well. So I want to give him credit before I begin my talk. So when you encounter a patient with hemoptysis, first of all, you really want to find out that is it a true hemoptysis or not. So let's look at the definition of hemoptysis. It is not as simple. We just don't take a hemoptysis as just a garden variety symptom. Hemoptysis means expectoration of the blood that originates in the infraglottic trachea and the distal respiratory tract. There is something called as pseudo-hemoptysis, and that is expectoration of the blood that has been aspirated into the respiratory tract from ENT areas or from the GI tract. Okay, so that is a pseudo-hemoptysis. These patients have more nausea, vomiting, they don't have pulmonary symptoms. The hemoptysis is acidic in nature because it is coming from the GI tract. You see food particles with that hemoptysis. There is no foam, there are no pus, there are no organisms, and there are no macrophages. So that is pseudohemoptysis. Also, pseudohemoptysis is encountered in patients with Serratia marcescens pneumonia because it's a very red color sputum, and patients may confuse this thing as hemoptysis. And also, when you give patients large amount of rifampin, I'm sure you have encountered this, that is called as red man syndrome, rifampin overdose, and if patient has got sputum under the circumstances, that would look red, and that is pseudohemoptysis. Now, hemoptysis is gauged or defined based on the amount of blood brought out in the sputum. Mild hemoptysis or streaky hemoptysis is referred as less than 30 cc's in 24 hours. Gross or frank hemoptysis, it is more than 30 cc's in 24 hours. However, it is less than massive amount, and that is a true diagnostic challenge for the clinician, even though there is no urgency with the frank or gross hemoptysis. And of course, for intensive care unit people, massive hemoptysis is truly a challenge. Exsanguinating hemoptysis, there is nothing much anybody can do, which almost leads to death. So I don't consider this thing as it is a big challenge because there is not much you can do. You just observe, watch the patient dying with this particular problem. Recurrent hemoptysis, the definition is that recurrent hemoptysis is that if the hemoptysis recurs with the interval less than 1 year, that is recurrent hemoptysis. So, having had defined the hemoptysis, Is the rate of bleeding clinically important? Why do we define this amount? And yes, it is very important. If the bleeding is about 400 cc's in 4 hours, as you see this thing, massive hemoptysis, if not properly treated, mortality could be as high as 70%. On the other hand, 400 cc's over the period of 48 hours is associated with only mortality or relatively less mortality of 5%. So yes, rate of bleeding is clinically very important and you need to pay attention to that. With that information again, let me talk to you about massive hemoptysis. That is a true management challenge for intensivists. The definition of massive hemoptysis is somewhat arbitrary. If you read in the literature, it has been defined anywhere between 100 to 600 cc's for 24 hours. However, all bronchoscopists and pulmonologists usually accept that if patient bleeds more than 200 cc's over 24 hours, it is massive hemoptysis. In my own words, in my own belief and my practice, if hemoptysis is threatening asphyxia, I would consider this thing massive hemoptysis. If patient is very small, even 50-60 cc's of blood could be a massive hemoptysis. The caveats related to massive hemoptysis that fortunately it is less than 5% of all causes of hemoptysis. Usually when you talk to the patient overestimates the amount of bleeding, amount of hemoptysis he or she is having. So you need to underscore that thing and you take it with a pinch of salt. Underlying lung function, as I mentioned to you, and not exactly the volume of hemoptysis determines the outcome. In a little short woman, a 60 cc's of blood could be life-threatening. Exsanguination is uncommon, as I mentioned earlier, and when patient has got massive hemoptysis, the death is not because of loss of blood volume. The death is because of hypoxemia. And let me ask you, let me, if all of you are paying attention, what is the capacity of left and right endobronchial tree? How much blood would require to fill up right lung and the left lung, total? Anybody, take a guess. How much blood it takes, if I give you 2 lungs, I say fill up the 2 lungs with blood, how much blood it would take?
200 ml. 200.
200. 100. 150. Dr. Samra has been following me for some time. Yes, it is 150 between 2 lungs. It takes only 75 cc's to fill up the entire endobronchial tree on one side. So what I'm trying to say that if patient bleeds 150 cc's, patient can drown in his own blood. Okay, so that's the only amount of blood which is required. Now, what is the most common etiology of hemoptysis? Non-massive hemoptysis. Over the period of last 50 years, the etiology of non-massive or mild or gross hemoptysis has changed from TB to bronchiectasis, lung cancer. Now it is acute over chronic bronchitis, or chronic bronchitis is the most common cause of non-massive hemoptysis. Unfortunately, the causes of massive hemoptysis over the period of last 50 years have not changed. Bronchiectasis, tuberculosis, lung cancer, abscess, and mycetoma remains the most common cause of massive hemoptysis, and I'm sure that is clear to all of them. Because of the time, I will not dwell on this particular slide giving you what causes massive hemoptysis in year 2011. Okay, once again, what is an exsanguinating hemoptysis? There is nothing much you can do. Risk to be life-threatening by asphyxiation and not actually by blood loss, but it could be by blood loss as well. Usually, it is more than 150 cc's per hour or total of 1 liter of blood coming out of the lung. What is the anatomical dead space of the airways? As I mentioned to you, it is 150 cc's to 200 cc's. When I'm talking to you about hemoptysis, just let for the sake of completion, what is an idiopathic hemoptysis? And all of you are lung doctors, and anyway, this is also referred as cryptogenic or essential hemoptysis. By definition, it is a single bout of hemoptysis. The patient has got minimal respiratory symptoms. Chest x-rays, CT scan, flexible bronchoscopy, and bronchial washings are usually normal when it comes to idiopathic hemoptysis. It is anywhere between 2 to 18% of all cases of hemoptysis. Unfortunately, the outcome of idiopathic hemoptysis is favorable. In 6 months, it does not return. Now I'm shifting the gears and talk to you very important part of hemoptysis. All hemoptysis are not the same. There are several sources of hemoptysis. If you just pay attention to and think about where the blood is coming from, you will be able to manage hemoptysis better. Okay? This is the anatomy of the lung in relation to the hemoptysis, or let's talk about the pathogenesis of hemoptysis. As you see here, this is adhesions, and there are blood vessels in the adhesions coming from the chest wall going to the lung, and this neovascularization can cause bleeding. There are blood vessels around the pleura, there are blood vessels around the alveoli, okay? There are blood vessels around the cavities. Pulmonary vein could bleed, pulmonary artery could bleed, bronchial arteries could bleed, bronchial vein could bleed, and even alveolar membrane could bleed. So when you see a patient with hemoptysis, even though majority of the patients, it is the bronchial circulation or it is the systemic circulation that bleeds, but also pay attention to other sources of hemoptysis, and if you think like this, you will be able to manage even the most difficult cases of hemoptysis. What am I trying to say here? Bronchial artery, bronchial vein, pulmonary artery, pulmonary vein, alveolar capillary interface, airway vascular communication, neovascularization, and rare causes such as pulmonary endometriosis, these are the sources of hemoptysis. So every time you see the patient, try to find out where the blood is coming from. Let me quickly take you through this. Source, bronchial artery. When an endobronchial tumor, when the lung cancer bleeds, it is bleeding from the bronchial artery. Systemic circulation, manage it accordingly. After I do the laser therapy, patient continues to bleed. What do I do? Bronchial artery angiogram and bronchial artery embolization. Okay? Because you know the source is bronchial artery where the blood is coming from. As simple as that. Lung cancer. 10% of all patients develop massive hemoptysis. 80% of this hemoptysis is related to squamous cell carcinoma. It is because of increased bronchial artery supply. It is also because of the necrosis of the mucosa or direct invasion of the blood vessels in the mucosa. All of you see lots of patients with bronchiectasis. What is the source of bleeding or hemoptysis in bronchiectasis? Massive hemoptysis it causes very often. It is bronchial arteries. If patient cannot undergo lung resection, what do? After doing local measures, bronchial artery angiogram and bronchial artery embolization. Okay? That is what I'm talking about. Look for the source. Go where the source is. Go where the money is. This is a normal relationship of the bronchus with the bronchial arteries. There are some 5 or 6 bronchial arteries, smaller in size, all around the bronchus. Okay, now patient develops bronchiectasis, and hence what happens? There is bronchial artery enlargement, and there is tortuosity, there is increased anastomosis with the pulmonary artery, there is hypoxemia as a result of that, there could be bronchospasm and inflammation which further leads to neovascularization. There are some budding capillaries in the granulation tissue, and that what leads to bleeding. As I was talking to somebody when I made rounds yesterday, signet sign on the CT scan. It is a sine qua non for bronchiectasis. And what am I showing you here? This is a beautiful signet sign of bronchiectasis. This is the dilated bronchus with a peribronchial cuffing, and you see a very large bronchial artery right here. Looks like a diamond ring on your finger. And this is the signet sign. And this bronchial artery bleeds. So if a patient with bronchiectasis bleeds and there is nothing you can do, think about bronchial artery angiogram and bronchial artery embolization. Now we are shifting to a patient with a large cavity, not per se from tuberculosis, from anything else. And you could see actually a bronchial artery bleeding into this particular cavity. As you can see it right here, it could be lung cancer, it could be mycetoma-related problem, or it could be any other cavity, it could even be TB cavity, yes. But once again, what I'm trying to show you, the source of bleeding, and you go after it in that fashion. This is a bronchial artery angiogram on your left before embolization, and if patient is bleeding profusely, you can consider this particular procedure in that fashion. So if you know the source, you can direct your therapy in that fashion. Tuberculosis, you know it more than I do. Why do these patients bleed? Exudative pneumonia, which leads to necrosis of the bronchial vessels, that leads to hemoptysis in the beginning. Endobronchial tuberculosis, which significant number of patients have, ulceration of the mucosa, also associated with bronchiectasis, leads to bleeding. There is fibrotic disease and granulation tissue associated with that. Neovascularization causes bleeding. Calcified lymph nodes can erode into the bronchial wall or bronchial vessels and cause a bronchial vein and cause bleeding. And last but not the least, Rasmussen's aneurysm. You have all heard about it. It is not a bronchial artery, it is a pulmonary artery which bleeds. So in a patient with chronic tuberculosis, and if you suspect Rasmussen's aneurysm, you want to go after the pulmonary artery and not the bronchial artery. So look for the source where the blood is coming from. I'm switching the gears now. I'm giving you a second source, pulmonary artery. All of you have seen patients with AV malformations. What is the source of bleeding in that case? Is pulmonary artery. There is no bronchial artery involvement here. This is a different source for hemoptysis, and there is pulmonary artery and pulmonary vein combination. That is what bleeds in this situation. And so what you do pulmonary artery embolization, embolotherapy. Once again, what I'm trying to say, look for the source, go where the money is, and direct your therapy in this particular fashion. And you do pulmonary artery embolization here, and you will see that you will stop the bleeding. And patients may require recurrent embolization in this particular fashion. These are the patients with Osler-Weber-Rondo syndrome or hereditary hemorrhagic telangiectasia, and they may require repeated embolization to overcome the hemoptysis in this particular fashion. Idea is source of hemoptysis. Airway vascular communication. Okay, we are putting stents. There's a stand outside, somebody is selling you self-expanding metallic stents, and there are several cases in the literature where the bronchus has ruptured into the surrounding blood vessel and patient develops airway vascular communication. This communication could be trachea to aorta, trachea to innominate artery, which could be seen in patients with mucormycosis, aspergillosis, Behçet's disease, trauma, radiation necrosis, or others. So be aware of that particular source. That blood can come directly from the aorta into the endobronchial tree, and patient could exsanguinate if there is prior history of stent placement, mucormycosis, so on and so forth. Neovascularization, and usually, now I'm talking about the third source, that is veno-occlusive disease, very rare, male, young patient, and the telltale sign, very interesting radiographic finding, curly V lines. The first lesson in radiology, there are 3 differential diagnoses for curly V lines. And what are the 3 differential diagnoses of curly V lines? Congestive heart failure. What else? Congestive heart failure, it is increased pressure. Pulmonary vein, what I'm talking, veno-occlusive disease, and lymphangitic spread of malignancy. It could be only 3 things and nothing else. So patient does not have malignancy, patient does not have congestive heart failure, and if I show you curly V lines, in a patient with a severe shortness of breath, hypoxemia, it cannot be other than pulmonary veno-occlusive disease. Again, it's very, very rare, and it is seen in tertiary care centers, but this is a veno-occlusive disease. Patient has signs, symptoms of hemoptysis as well. What I'm trying to show you, once again, a different source of hemoptysis. There is very little you can do for this patient, probably except lung transplantation. Fourth source of hemoptysis, neovascularization. As you know, patient has got either aspergilloma, that you have lots of pleural thickening here. You see it right here, that is a sign of aspergilloma, a fungus in the cavity. It is usually associated with pleural thickening, lots of neovascularization. That's where the bleeding takes form. It's a systemic source of bleeding, and similar thing is seen after radiation therapy. Fourth or fifth source of hemoptysis. In last couple of minutes, what else could be the source? Alveolar capillary interface, and Rajesh asked me to talk about this particular thing because he says ICU physicians see lots of pulmonary hemorrhage, and what is the cause? So what is the source here? It is not bronchial artery, it is not pulmonary artery, it is the alveolo-capillary interface. And Goodpasture syndrome is a perfect example where the blood is coming from the alveoli. You have seen the chest x-ray, you have seen the transbronchial biopsy, and you have also seen immunofluorescence staining confirming the diagnosis of Goodpasture syndrome. These are the conditions where you see the blood coming from alveolo-capillary junction or interface, and that is often referred as alveolar hemorrhage syndrome. Is Rajesh in the crowd?